Backache and renal failure. Scenario: a 60-year-old man is referred to the medical admissions unit with general malaise and lower backache. On examination, he is dehydrated and there is tenderness over his lumbar spine. Initial investigations reveal serum calcium of 3.2 mol/L and creatinine of 275 mol/L. Introduction. The priorities with hypercalcemia are to rehydrate the patient, control the hypercalcemia and establish a diagnosis. The main causes of hypercalcemia are shown in Table 9. In this case, myeloma seems the most likely diagnosis, Fig 18, but other malignancies with lumbar metastases should also be considered. History of the presenting problem. Hypercalcemia can cause many symptoms, Table 10. Ask about these, they may give a clue as to how long ago problems began. NB. Chronically high serum calcium levels cause neurological, gastrointestinal, and renal symptoms, depressive moans, abdominal groans and renal stones. Other relevant history. Ask in particular about the following. Weight loss, a general feature of malignancy. Pointers to a primary tumor, e.g. hemoptysis and rectal bleeding. Drug history, including over-the-counter medications, antacids and white medicine, and vitamin supplements, cod liver oil or vitamin D, which many patients do not regard as drugs. Examination, general features. As always in an acute context, it is vital to make an initial assessment as to how ill the patient is, but the details given here do not indicate that the patient is likely to be very ill. Note particularly the following. Fluid status. The details given state that the patient is dehydrated, but is there clear evidence of intravascular volume depletion, postural drop in BP and low JVP, and/or dehydration, reduced skin turgor and dry mucous membranes and axilla? Evidence of malignancy, in particular, are any lymph nodes palpable? Are there any chest signs? Feel carefully for any abdominal mass or hepatomegaly, and do not forget rectal examination. Look for localized bone deformity or tenderness. In a woman, check the breasts. NB. Hypercalcemia increases urinary sodium and water loss. This causes dehydration and a fall in glomerular filtration rate, which further reduces urinary calcium excretion. Investigations. Blood tests. FBC and blood film. Is there anemia? Are there rouleaux suggesting myeloma? See Fig 19. Sodium and potassium. Calcium and creatinine, to monitor for deterioration or improvement. Liver and bone function tests may give clue to malignancy. Immunoglobulins, serum, and urinary electrophoresis. Look for monoclonal band in serum, Bence-Jones protein in urine and immunoporesis, all suggesting myeloma. Parathyroid hormone will be suppressed by any cause of hypercalcemia other than hyperparathyroidism, when it will be high or inappropriately, given hypercalcemia, at the upper limit of the normal range. Serum angiotensin converting enzyme, if sarcoid is suspected. Imaging. CXR, bony secondaries and lung cancer. Skeletal survey, lytic lesions and features of myeloma. Kidneys, ureter, and bladder radiograph, nephrocalcinosis and urinary stones. Ultrasonography of urinary tract, obstruction, nephrocalcinosis and renal stones. Other investigations, as clinically indicated. Examination of bone marrow, look for excess plasma cells. Diagnostic of myeloma, Fig. 20. Sepsis screen, urine, blood, and other appropriate cultures. Renal biopsy, sometimes appropriate in myeloma with renal impairment to establish the nature and chronicity of damage, and hence the potential for reversibility. NB. Hypercalcemia and myeloma. Hypercalcemia occurs in about 25% of patients with myeloma. Myeloma cells secrete osteoclast mobilizing and stimulating cytokines, and osteoclasts secrete interleukin-6, which is a growth factor for myeloma cells. Bone destruction is caused by osteoclasts related to collections of myeloma cells. Osteoblastic activity is reduced, so bone scans are usually negative in myeloma. Management. Fluid. Whatever the cause of hypercalcemia, initial management is to correct volume depletion while carefully monitoring the patient and his urine output to ensure that you do not overload him in the relatively unlikely event that his renal function does not pick up with volume expansion. Correct volume depletion. This may require several liters of intravenous 0.9%, normal, saline. Give 1 L over 1 TO 2 hours and then reassess clinically. Repeat until signs of hypovolemia have been corrected. No postural drop in BP and JVP easily seen. Consider giving a loop diuretic, e.g. furosemide 40 to 80 mg to increase urinary volume and calcium excretion if urine output is below 100 ml/hour, probably of little benefit if the patient is polyuric. After restoration of circulating volume, further fluid management should be dictated by urinary output. Urine output satisfactory, greater than 100 ml/hour. Ensure that fluid input, oral or intravenous, is enough to sustain a urine output of 3 L/day, but monitor this closely and reduce input if urine output not maintained. Urine output not satisfactory. This indicates that volume depletion is not the sole explanation for renal impairment. Prerenal renal failure, and other pathological processes are involved, e.g. myeloma kidney, acute tubular necrosis, urinary obstruction. NB. Fluid management in the patient with renal impairment. Ensure adequate filling, no volume depletion, no postural drop in BP, no low JVP, and no volume overload, breathless, high JVP and basal crackles. Give input equal to all measured outputs plus 500 to 1000 ml/day for insensible losses. Examine patient at least once a day for signs of volume depletion or overload and adjust input as appropriate. Other treatments for hypercalcemia. If the patient's serum calcium remains very high, greater than 3.0 mol/L, or he continues to be symptomatic from hypercalcemia, further therapy for hypercalcemia might include bisphosphonates or steroids. Bisphosphonates. The POP bond of pyrophosphate is cleaved by a phosphatase during bone mineralization and in osteoclastic bone resorption. Bisphosphonates contain a PCP bond that is resistant to cleavage. They bind tightly to any calcified bone matrix, impairing both mineralization and resorption. Disodium pamidronate is commonly used to treat this, up to a maximum of 90 mg by slow intravenous injection. Steroids, e.g. prednisolone 20 mg daily, are very effective in hypercalcemia caused by sarcoidosis, and may be of some more limited use in hypercalcemia caused by vitamin D intoxication or myeloma. They reduce calcium absorption in the gut, reduce the production of osteoclast-activating cytokines and can induce tumor lysis. They usually take 1 to 2 days to act. Management of myeloma. Note that the 1-year survival rate for patients with myeloma who require long-term dialysis is only 50%. Further comments. Does renal impairment need investigation if there is hypercalcemia? If renal impairment does not completely correct with rehydration and other measures to lower serum calcium, then it is essential to find out why. For further discussion, but the key elements include the following. Dipstick of urine and urine microscopy, proteinuria and hematuria would almost certainly indicate kidney myeloma, but could also indicate another renal inflammatory lesion, e.g. malignancy-associated glomerulonephritis. Renal ultrasonography, what is the renal size? Is there obstruction? Daily check of fluid input, urine output, and patient weight, with appropriate fluid management to ensure that the patient does not become fluid depleted or volume overloaded. Daily measurement of renal function and serum calcium.